Hello, good evening. Welcome everyone. Thank you for joining us tonight for session 2 in our series, The Clinical Benefits of Multidisciplinary Team Care in Residential Aged Care Facilities. And tonight's topic is chronic disease management. My name is Charles Broadfoot and I'm one of the Professional Development Officers with Hunter New England Central Coast Primary Health Network. I would firstly like to acknowledge the First Peoples and traditional custodians of all the lands in which we are meeting on tonight and pay my respects to elders past, present and emerging. I'd also like to extend my welcome to any Aboriginal people who may be joining us online as well. The session tonight is being recorded and the recording and the PowerPoint slides will become available from tomorrow in our education library on our website. So to access these, you just head to our homepage, thephm.com.au, and click on the Education tab. We will be using Slido tonight for your questions as well as the session evaluation survey. You can see on the right-hand side of your screen, there's a polls and Q&A tab if you're joining us on a laptop or computer. Alternatively, you can head to slido.com, so that's SLIDO, and enter the event code for this evening, which is AH2, so which stands for Allied Health, and then the number 2. Or a third option is by scanning that QR code on your mobile device, which has popped up in the corner of your screen. So please type your questions in throughout our presentations tonight, but please know we have allocated time after the presentations to go through these with our presenters in a panel discussion. It's now my pleasure to introduce tonight's facilitator, Dr. David Healy, GP from Faulkner Street Medical Practice in Armidale. David is a long-standing rural GP and he has training in aged care and palliative care. He has worked for many years caring for residents in aged care facilities. So thanks again, everyone, for joining us. I'll hand over to you, David, to introduce the session and tonight's speakers. Thanks.
Thank you very much, Charles. So tonight's session will discuss the following: a brief overview of the relevant findings of the Royal Commission into aged care quality and safety, an in-depth explanation of the temporary MBS item numbers available to allied health providers in RACFs to encourage uptake, an explanation of the Aboriginal and Torres Strait Islander health assessment and benefits to eligible residents within our aged care facilities. There'll be a discussion of the roles that GPs, allied health and aged care facilities can play to effectively implement these initiatives in order to achieve best outcomes for residents, and how to best integrate these new initiatives into general practice business. There will also be a description of the relevant Department of Veterans Affairs treatment cycles. We'll also have an overview of the role of a diabetes educator and a dietitian for patients with chronic disease, including some case studies. Our first speaker is Wendy O'Meara. Wendy is an Associate Education Consultant with LATA Consulting, as well as a registered nurse and practice manager. She comes from Gisborne in Victoria. She has a long and diverse history in general practice, spanning 20 years. She began as a nurse in a general practice in the year 2000, before moving to her current role as Senior Operations Manager in a 20 GP general practice. So I'll now hand over to Wendy, who'll present the topic of chronic disease management within residential aged care facilities. Over to you, Wendy. Thank you.
Thank you, David. Very nice to be here tonight, everybody. As David said, my role tonight is to explain the new initiatives that are available to you in residential aged care facilities. I can't see my presentation at the moment. There we go. Thank you. So, as I said, my role tonight is to explain the new initiatives that are available to general practitioners and to allied health providers. as a result of the recent or the Royal Inquiry into the quality and safety of aged care that was conducted last year. So it is quite a bit to go through, so I'll just jump straight into it. So at the end of tonight's session, all the participants will be able to discuss the important contributions that general practice plays in facilitating access to allied health services, particularly for those residents with complex medical needs. Describe the new item numbers that are available now for allied health to provide additional services within the aged care facilities, and to locate the information sheets. An outline of how to refer a resident. So what the requirements are for both the GP and what the requirements are for allied health to meet the criteria of the MBS. And a discussion amongst our colleagues on how to deliver these collaborative services efficiently to minimise the disruption to everyday life. So just a bit of snapshot for all of you tonight. At the moment, this is taken as of the 22nd of October 2021. You can see this is this current year from July 1, how many outbreaks we have had in aged care facilities. I guess the area I'd like you to draw your attention to is the recovered cases right down the bottom. There's been 2,605 residents in aged care facilities who have contracted COVID and recovered. So I think it's important that we focus our attention on those people tonight to see what we can do to help their recovery along. The impact of COVID-19 has probably been the greatest challenge the aged care sector has ever faced. The significant impact on the residents, both physically and socially and mentally, has been profound. Not to forget the impact on the families and, of course, the staff members of the facilities. So we weren't prepared for this. It hit us, come out of nowhere, and we were so unprepared. So we have learned a valuable lesson from this pandemic, and hopefully what's been made available to us now will also allow us to change the lives of these residents, get them back on track, get them back to their independent quality of life. So the statistics. So just again, a brief overview. As of the 22nd of October, there have been 774 deaths in aged care in Australia. So unfortunately, Victoria leads the way with 683 due to our nasty outbreak that we had mid last year. And New South Wales at the moment are currently sitting at 82 deaths since your recent outbreak, since July. And of course, the remaining numbers are made up from the other states and territories. And there have been 457 cases in aged care facilities in New South Wales since the 1st of July. So there's been a significant amount of aged care facilities impacted, and the residents as well. So let's put it into some context. Where is this initiative coming from? So it is a direct result of the Royal Commission inquiry into the quality and safety of aged care within Australia. It was instigated in 2018 by the Governor-General, Sir Peter Cosgrove, as a direct result of the growing number of complaints and concerns regarding the care received for our elderly population, not just in aged care facilities, but within the community as well. The final report was tabled in March 2021 this year. Having said that, the scope of the commission did cover, obviously COVID hit between 2018 and now, so the inquiry was redirected, I guess, to the impact of COVID as well. So even though it wasn't a great thing, it was timely to look at how this affected us or how it affected this area. So of the report table, there were 148 wide-ranging recommendations for the fundamental reform of the aged care system. So major overhaul time. What I'm going to talk about tonight are the three most relevant to the presentation that I'll be presenting to you. So the recommendation 60, I beg your pardon. So the first recommendation, number 3, states that the Australian government should urgently create Medicare benefit schedule items to increase the provision of allied health services, including mental health services, to people in aged care during the pandemic. Any barriers, whether real or perceived, to allied health professionals being able to enter residential aged care facilities should be removed, unless justified by public health reasons. So what does this mean? So the government has been advised they must increase the allied health services available to these residents, because as we know, the most significant impact of COVID for these residents has been deconditioning. So deconditioning requires, and the most beneficial treatment for deconditioning is physical therapy. And of course, the barriers are about making sure that there is access to services. So not stopping these allied health professionals from coming into the facility and working with the residents. Recommendation 38 is to ensure that there is a level of allied health care appropriate to each person's needs by no later than the 1st of July 2024. So obviously, I think the key words there are appropriate to each person's needs. A lot of the allied health provision in aged care is based around the aged care funding and not actually specifically to the individual needs of those residents. Arrangements must be made between aged care providers and allied health for provision of services as required, and they must either employ or retain a range of allied health providers to ensure provision of care for the residents is in accordance with the individual care plans. So that's a great thing. That's certainly going to make a difference to what can be provided to these residents. And the final recommendation, number 61, is that to create the new MBS item numbers by the 1st of November 2021, which, I beg your pardon, they actually should be 2020, for allied mental health practitioners providing services to RACF residents. This is purely just an information and a bit of a precursor to the third session where we're going to be focusing completely on the mental health component of these new item numbers. And that will be available for psychologists, OTs and social workers. This funding will cease in June 2024 when the new aged care allied health funding becomes available. So just something to think about for the next session we'll be having in a few weeks' time. So, allied health. Allied health providers play a significant role in maintaining the quality of life of residents in aged care facilities. The lack of activity and exercise significantly impacts physical function. So we have to think back to the times when our residents were isolated with outbreaks within the facilities. Some of them were quarantined to their rooms for weeks at a time. Some of them were in hospital for long stays due to recovering from COVID. So they have been severely deconditioned. And of course, we need to focus on that in the way forward. They have lost their strength. Sorry, my phone is really, I'm having trouble with these PowerPoints. Mobility and balance. So all of those have been affected. And what that does is significantly increase the risks of falls, which significantly increases the risk of hospitalisation. And of course, the effect on their cognitive and mental health, which I've just mentioned, results in increase of falls and hospital admissions. So what have we got available to us now? From the 10th of December 2020 to the 30th of June 2022, hence the name, the reference to the temporary MBS item numbers, the government has, or MBS has introduced a temporary range of item numbers available to improve access to multidisciplinary care for residents in aged care facilities. Thank goodness. What it means is they are now an additional 5 physical therapy services and an additional 2 additional group therapy services for exercise physiology. So at the moment we have 5 services available in total. This is giving us a further 5 plus a further 2 group sessions, which takes the totals to 10 individual services and 10 group sessions per calendar year. So if anyone's thinking like I am, it's October, nearly November, now's the time to get these referrals happening so we can get as much as we can between now and the end of the year so that we can start again in January. So it's been implemented in recognition that residents of aged care facilities are at high risk of deconditioning as a result of restricted activity. And again, taking us back to the lockdown times and even just the fact that the staff have had their focus on infection control, they haven't had the time to be giving the personal attention to the residents that they require. due to reduced activity, reduced family support. Families have been isolated from their loved ones, haven't been able to come in and look after them or take them for a walk. Even things like just walking down to the dining room. You know, some of the residents, when I was reading the Aged Care Commission report, there were residents that were actually isolated or quarantined in their room for 6 weeks without any contact. And of course, as I said, the staff's focus on infection control had a big impact on what service delivery was available to those residents. And as I also said before, many residents have contracted COVID-19 and recovered. And we need to get these services available to them, or these therapies available to them, to get them back on their feet, to regain their independence and to just regain that sense of achievement. Okay. In order to be eligible for these services, the resident must be currently managed under one of the following: either a multidisciplinary care plan, which is the care plan created within this facility, a GP management plan. Now, you can actually use, if you have a resident who has been previously managed under a management plan within general practice, prior to being admitted to an aged care facility, you can actually still use the 732s or the equivalent item numbers to manage their chronic conditions. So it can be one or the other, can't be both. The shared care plan, and of course, team care arrangements. Sorry, I'm really having trouble. And the new Aboriginal Torres Strait Islander health assessment. So this has not been available to residents of aged care facilities prior to December last year. So anyone who has residents within the aged care facilities are now able to conduct a health assessment for them, and I will give you a bit more of an explanation about that shortly. So what does it mean? I'd like to spend a little bit of time on these few slides because these are the crux of the whole thing. So for GPs who are attending tonight, what does it mean for you? Basically, prior to December last year, when you reviewed the care plan of your resident, you billed the item 732, which was done every 3 months in conjunction with the aged care facility. So you'd go into the facility, you review your care plan, and you bill your 731. From that visit, you would then implement your 5 visits to the allied health professionals. So diabetes educator, dietitian, physio, chiropractor, any of those services. Now, when you go into the facility to do exactly the same thing, you need to bill the 93469. So that is important. If you continue to bill the 731, Medicare will not flag to Medicare that you are wishing to refer those additional 5 physical therapy sessions, and the allied health provider will not be able to claim the rebate. So it's very important that you remember the 93469 is the item number you would use for your general residents, and the 93470 would be the one you would use if you're reviewing the plans of an Aboriginal Torres Strait Islander. So GPs, this is the key point for you tonight, that you must bill these item numbers. For the allied health professionals, it's a little bit more complex. So I've listed the most common service provisions here. I'm just going to focus on one. Let's look at dietetics, for example, or diabetes education. So currently a diabetes educator, when they are seeing a resident, uses the item number 10951 or the telehealth equivalents of either 93000 or 93013. What's also been introduced, which I'll discuss for you in a moment, is a new initial or long attendance consultation. So that's one initial consultation per person from a new referral or from an existing referral when you would like to initiate the first visit. So that will be a 93502 in this case as a face-to-face. However, that's it. So that initial one attracts a higher rebate, and then you have the other 3 item numbers, which is the face-to-face, the video, or the phone consultation. I know it looks a bit clunky and a bit confusing, but if you focus on the fact that on the left-hand side of the screen is the current existing item numbers, on the right-hand side of the screen, the first column is the initial consultation, and then the rest of the item numbers are for the first 5. So if you're using the initial consultation first, you'll then have 4 remaining from there to make up the first 5. I hope that makes sense. I am mindful of the time, so I'll keep moving on. But these slides are available to you as other links to the cheat sheets as well. This is the same information, but based on services provided under an Aboriginal or Torres Strait Islander health assessment. So by conducting the health assessment, you are able to refer exactly the same as if you are doing the care plan review. So that's just the equivalent of that. And then we have the, sorry, my slides just doesn't want to move. There we go. This is the additional physical therapies. Now, as I said before, the 5 additional therapies are for 5 additional services are for physical therapy only, and only apply to these 3 service providers. So exercise physiology, OT, or physiotherapy are the only 3 providers who can access the additional 5. Any other provider is able to access the initial 5, but the remaining 5 must be physical therapy. And as you can see here, the item number is what's on the right-hand side of the screen. So existing item numbers are 10953 for EP, for example, but the new item numbers, which will be flagged as the additional 5, are 93518. I really hope it makes sense. It does to me now because I've been looking at it for quite a while, but I'm happy to take questions at the end if anyone's not quite sure. And of course, then we have the therapies. Oh, goodness me, this just doesn't want to work for me tonight, this clicker. Todd, could you just go next for me, please? There we go. Another great announcement is the addition of the flag fall fee. So now allied health providers, just like GPs, can, when they attend a aged care facility to see a resident, can charge a flag fall fee or claim a flag fall fee for the first resident of that visit. So if they go and see only 1 resident, they claim it once. If they go and see 10 residents, they claim it once. So it's just for the first service, but it is an added incentive to try and attract the allied health to aged care facilities. So the government is definitely trying to improve the revenue available to them to attract the services, because as we know, it's great to have this service or to have this initiative, but getting the providers is going to be the challenge here. And then we have the item numbers for group services. So these are applicable to the exercise physiology, OT, the exercise physiology only, I beg your pardon, for the group sessions for those final 2. Okay, so in a nutshell, to sum it all up, what the changes mean. I'm so sorry, but I just can't seem to get my slide moving. At the moment, the initial program, we have up to 5 allied health services for a full range of providers. So anyone that you can think of to refer to, as I said, diabetes educator, dietitian, chiropractor, speech pathology, you are still able to refer those 5 further services. And we have 8 group sessions for residents with type 2 diabetes, and they are available for dietitian, exercise physiology, and diabetes educator. With the new program, what the changes mean is that now I'm so sorry, up to 10 allied health services with the addition of 5 physical therapies. So as I said, up to 10 for the calendar year. 5, the first 5 can be of any provision, service provision that you choose, but the additional 5 must be for physical therapy. And they include, as I said, the physio, the OT, and the exercise physiologist. Yes, so up to 10 sessions, 2 additional, and 5, with the original 5 no longer need to be used. So what I would like to just briefly touch on here, previously, before the 1st of October, we had a bit of an issue with the referral of services. So the guidelines stated that the additional 5 could not be accessed until the original 5 had been used. So that became a problem when you have someone like a podiatrist getting the 5 services, because they're spread out over a 12-month period, which means that there may never be the opportunity for those people to actually access the services. So the government has removed that, or Medicare has removed that. So now, regardless of how many services, there is the availability of 10, whether the first 5 have been used or not. So if you're a physio, for example, you can use your 5 services regardless of whether the podiatrist has used their first 5. So that's great news. So Medicare's getting with the program. Okay, so the MBS requirements for this initiative, as we said, the allied, so this is for the allied health provider. They obviously must be registered with Medicare. Feedback must be provided to the practitioner after the first and final service. That's really important. You must be providing feedback to the GP on after your first visit, so that extended consultation about what services you're going to provide, and after the final service too, so they can see the summation of what you've done. The referral must be on the appropriate form, indicating the number of services that you are referring for, and a separate referral must be provided for each of the allied health that you're referring to. And the services must be 20 minutes long. So that's the MBS requirements around the allied health provider number requirements. So what's new? As I said, the introduction of the initial consultation. This is fantastic. So it's a minimum of 30 minutes. It is a high rebate for allied health professionals to claim, which makes it a more viable financial model for them when they attend the facilities. It is part of the 10 sessions. So of the total 10, the initial consultation does make up one of those, and it does attract a higher rebate. It's $96.30, but that's the 100%. So I do believe it's about $89 for the 85% that you can claim. And it can be claimed by each provider engaged in the care of this resident. So if you have 3 different service providers conducting those total of 10 sessions, those 3 providers can all charge the initial consultation when they see the resident for the first time. It must be provided face-to-face, so there's no telehealth or telephone component of this. And of course, don't forget the flag fall fee, which is $41.65. So when you're looking at that, you're looking around $120, $130 for the first service when you see the first resident. So it does make it more financially viable. What I will say also is that there's no mandated, it's not mandated that their services must be bulk billed. So as a physio or another provider, you can charge privately to the resident as long as you make the resident aware that there will be an out-of-pocket. So it's not like the telehealth where you must bulk bill. It is absolutely possible to charge privately, and many residents are just so grateful for the service that they don't mind paying. But as I said to you, you must provide them with financial consent or informed financial consent. So in addition to these services, there's also been a targeted measure which is available to certain PHNs within the Sydney region to provide group therapy sessions to residents as well. So on top of what we've already been given in the funding, there's also the PHNs have been commissioned to provide group allied health services, again, for those 3 main providers, which is your physio, exercise physiology, and OT. What's required for those group sessions is that the allied health provider will meet with the aged care facility and identify eligible residents, undertake a one-on-one assessment to identify that person's needs, which is so important. It's not just about it's not one group, it's each person. And then those people will be placed with groups that are relevant, the therapy is relevant to their programming. And they will then provide 6 months of twice weekly group sessions, which is fantastic. So that's in addition to everything else that we've been talking about tonight. So that's something else to be aware of. Now, with the Aboriginal Torres Strait Islander Health Assessment, as I said, it hasn't been available to the residents of aged care facilities before. So this is fantastic that they've finally got this happening. It can be conducted the same as the community one every 9 months. Excuse me. And it allows the referral to these temporary item numbers. So you don't necessarily have to be, the patient or the resident doesn't need to have a review of the care plan to access these services. They are available purely by engaging and conducting the health assessment. And again, it allows the access to those additional 5 therapies and the additional 2 group therapy sessions. It does attract the flagfall fee. So as a GP, if you're attending to do this health assessment, it does attract the flagfall fee, and you can continue to use your practice nurse to assist you with this. But it also allows those additional, so not just are you getting the 10 physical therapy or the 10 sessions, but you also continues to allow access to both practice nurse and Aboriginal health worker follow-ups as well. So it's really great to have this done. So please keep this in mind for any residents that you do have that meet this criteria. Something I would like to touch on, which is relevant in a way, and I know a lot of GPs are not aware of this, is the Dva treatment cycle. This has been around for a couple of years already, and it surprises me how many GPs are actually not aware of this, what this is. So basically, with anyone who holds a gold card, they are able to be referred for what's called a treatment cycle. So it's the one cycle is equivalent to 12 visits or 12 months, whichever comes first. So, and the actual treatment cycles, there can be as many as is required. So if you refer one of your residents to a physio, for example, for the first 12 first 12 visits, and the physio comes back to you and says, we're really getting somewhere, or to the diabetes educator, I'd like to continue on with these services, then the GP can refer for another cycle of care. And there can be as many cycles as the GP and the allied health professional deem necessary. And there can be multiple cycles within one year. So you can have 3 or 4 different providers all providing DVA treatment cycles. So this is something that's been around for a couple of years. Again, it's not well used, so it is worth thinking about this when you're looking at your DVA residents, particularly for those in the aged care facilities. They are, initially it was related to funding, so it was mainly the low-level residents or the low-care residents, but it's actually been expanded to include both high and low care. So all of those residents are eligible now. Excuse me. Again, an initial consultation must be conducted to create a care plan, and a final report must be provided from the allied health professional to the GP at the completion of the cycle to explain what service was provided and where you're at with the cycle of care. And the best news to come out of this is new, and I'm really excited about this, is from the 1st of November, allied health providers are now able to not only participate in case conferencing, because they've been doing that for a long time, but now they're actually able to charge or claim a rebate for it, which is about time. So there are 3 item numbers being introduced for allied health to participate in case conferencing. Obviously, the patient or the resident must be managed under a multidisciplinary care plan. Please keep in mind this is both aged care facility and the community. So it's not just for aged care, it is for both, which is fantastic. It's the case conference must be instigated by the GP. However, it can be instigated by the GP at the allied health provider's referral or recommendation. So allied health providers get those recommendations going. There is a no existing rule relationship, which means the allied health provider does not have to have seen the resident in the past to actually participate in the case conferencing, because often it's about getting together with the GP and other providers to actually work out what you're going to be providing for this resident. So that existing rule doesn't apply, and they can be claimed every 3 months. There must also be 2 additional providers besides the resident. So the family and the resident's family, the resident and the family should be in attendance, but they don't make up the providers. So you must have 2 additional providers, and there can be 2 allied health providers and a GP. So if we're looking at tonight's lovely speakers, we could have the diabetes educator and the dietitian and the GP, and that would make up a case conference. And it can be done by telephone and telehealth. So this is fantastic news. I don't actually have the rebates available, but I do have the item numbers. So the rebates are not available yet. I looked at them 5 minutes before I came on tonight, and I still went there. But these are the 3 item numbers, and as you can see, they are based on time. So exactly the same as a GP can claim. 15 minutes, but less than 20. 15 minutes, but for less than 20, then 20 to 40, and then 40 plus. So as I said, the same service provision as we can currently currently claim is in general practice land, but now is available for allied health. So this has been a long time coming. I'm really excited to see this happening, as are a lot of other people. Now that we've discussed what's available, I'd like just to briefly touch on the role that each of us play in making sure that we can get our residents the access to these services that they need. And it all starts with the GP. The GP is going to be the driver of this program, and without the GP's engagement, it's not going to work. The GP, since COVID-19 hit, obviously there's been a reduction of visits to the aged care facility, so we were with limited access. During the worst times, we weren't able to see our residents face to face, and a lot of it was just through nursing intervention, or the facility contacting the GP to give us, what they need. There was very little contact, which was such a shame, and that was mainly because of the outbreaks, and I can understand it. And I think this is where it goes back to the Aged Care Commission saying that those barriers need to be removed. But limited access to them meant the GP became more proactive than reactive. So moved from proactive to reactive. So instead of managing our chronic disease residents, we were actually just reacting to requests from the nursing home or the facility, to treat the residents. We weren't actually seeing them. And there were reduction in service provision to residents across the board, not just GPs, but through the allied health sector as well. Sorry. We stopped doing routine visits. The wound care management was non-existent, apart from what the aged care facility were doing, because we weren't able to get in there. And of course, chronic disease management went way by the wayside. And of course, medication reviews, which are a vital component of our looking after our residents, is managing their medications, and all those things not ceased, but they were all put on the back burner, with particular reference to chronic disease, which is at the worst time because it's when they needed it the most. So when I asked GPs what the barriers are to providing care for the residents in aged care, most common responses I got were the lack of trained staff to assist the GP. So the GP presents to the aged care facility. There's no one around to give them a handover. There's no one there to take them around and speak to the residents. That became a real barrier for a lot of GPs. The other thing was the complicated workload that residents present. So they're not just a simple pop-up, deal with something and then go back to the clinic and get on with your day. The number of faxes and phone calls you get each day, particularly if you have a large number of aged care residents, which I believe our lovely David, the facilitator tonight, has quite a lot. So he probably appreciates that. But also the poor remuneration for service. So we weren't getting remunerated properly for what the time that it took, and of course the time that each resident takes. Quality of the care plans were also an issue. Many GPs comment on the fact that the care plans were based around funding models and not about the care that the actual individual needed. So these all became, huge barriers to providing care. But when we look on the flip side of it, the incentives for care provision are rewarding. So for both the practitioner and the resident, particularly, we've got to remember that these residents have probably been looked after by a GP, the same GP for 30 years, and have moved through the community setting and into the aged care sector. And this GP is such a vital part of their livelihood, of their life. Incentives for us also are to initiate appropriate services for our residents, to actually go there and say, what can we do for these residents to give them quality of life? What services can I refer to for my resident to make them, to give them their independence back, or to regain that independence they've lost during the last 12 months? And now obviously the increased financial incentives through the new initiatives have helped to get GPs and clinicians back into aged care, but we could still go a lot further. The other thing that's improved significantly is the aged care access incentive. So previously it was based on a $5,000 cap per year for the number of services that you provided. Obviously, the practitioner or the practice needs to be registered with the practice incentive payment to access this payment. But now you can access double that. So based on a tier level, as you can see, from 60 to 99 services, the initial payment is $2,000. and then it goes up in tiers up to the 180 plus, which gives a total of $10,000 available to a GP per financial year to provide 180 services, and it's services, not visits. So one visit could actually promote or instigate 4 or 5 services. So it's not hard to get to that level if you've got more than 5 or 6 residents in an aged care facility that you see routinely. So that's great. Efficient service delivery. How do we as GPs ensure that we're going to get this happening? So we need to go back to our clinics, and we need to generate some reports that show us when we last billed our care plans, our CMAs and our mental health plans, and look at when they're due to be reviewed. Get a copy of the care plan from the aged care facility and schedule some time in to go up there and review those plans and get these referrals happening, get those referrals initiated, and get these residents getting some treatment. So what can we do as GPs? We need to recommence and continue to regularly review our residents, add reminders into our clinical software for when our care plan reviews are due, so that we're mindful to generate those and do those referrals, and same with our health assessments. Assist the aged care facilities to create a patient-centered care plan. Go to the facility and have your say in what happens with your residents, and engage other providers so that we can ensure we get optimum care for our residents. Schedule regular reviews and encourage upload to the shared health summary as well, because that also is available to external providers should our residents end up in hospital. Okay, residential aged care facilities. I am mindful of the time, so I will try to be as expedient as I can. How do they contribute? Obviously, general practice can't do this on their own. Collaboration is essential. We need to work with our aged care facilities to create patient-centered, holistic care plans that focus on what is required for each patient to regain their independence, whether it be allied health services, physio, exercise physiology, diabetes educator. All of those services must be involved. We need to actively get involved in the care outbreak planning so that we can ensure our residents are looked after should we have another outbreak. We need to put in place plans that the GP can contribute to, so that we can be in control of how our residents are cared for. Please make the aged care, the files available, or the resident's file available to the GP. They can't contribute to a care plan that they can't see, particularly things like care plans, pathology imaging, and discharge summaries from hospitals. So as an aged care facility, having these available to the GP and the allied health providers when they attend will assist them to promote good best practice and give them an opportunity to provide what those residents need. Invite GPs to participate in the care plans and have those COVID-19 specific directives, so that if worse scenario happens again, that we're able to actually direct the care that our residents receive. Please make the staff available so that when GPs attend, they have got someone to assist them. Makes things so much easier. If you're going to go down the IT path where you have telehealth requirement, make sure there's someone who's there who can actually use it, so that it's available for the GP to participate in, and that the aged care facility has someone with the resident who can actually assist them, because the elderly aren't very tech savvy when it comes to iPads and laptops. Again, aged care facilities need to be able to recruit and maintain service provision of allied health, and they should be involving the family in the planning of the care of the resident. And please organise regular visits to meet with the GP and the allied health to discuss quality improvements within the facility and how we can all work together to get the best for our residents. And of course, the most important people in this are the allied health. What role do they play? As I've said more than once today, allied health plays a significant role in maintaining independence and regaining or reconditioning residents post-COVID-19. It enables them to function better physically, socially, and emotionally. Allied Health provide a diverse range of interventions that can help to get them back on their feet. You know, we've got so many different service provisions available, and being able to and referring our residents for these services is so important. And of course, the prevention or slows the progression of conditions. Obviously, deconditioning, a natural part of aging is a certain component to deconditioning. So we do naturally achieve deconditioning, I guess, just because we get older. But the impacts of COVID-19 and the deconditioning around that lack of physical activity, we can certainly do something about. It empowers people to live fuller, healthier lives. So again, Allied Health can contribute by also having a say in the care plan, being able to actually access the aged care facilities care plan and have some say in what they provide, and not be told this is the funding we've got, so this is all you're able to do. Schedule routine visits to see the residents and discuss and regular discussion with the aged care facilities about what you'd like to provide. Give them some suggestions about some group therapy or some what you'd like to implement for each of the residents, and make it become part of their care plan. Create a plan that the aged care facilities can help you with. So there are many aged care facilities have allied health assistants now. So as a physio or any provider, you can create a service that will allow the aged care facility to help you to continue that provision of service when you're not at the facility. And that can become things like exercise, diet, and group therapies. I'm sorry, I just missed one there. So finally, I'll just go back one. This is a link to the, it's not going to let me go back. This is the link to each of the MBS guidelines that are available to each different area. So please feel free to have a good look at that. It does explain it in much more detail, particularly item numbers, because they can be quite confusing to start with. But people, in a nutshell, the effects of COVID-19 on our elderly Australians has been nothing short of devastating. We need to provide multidisciplinary, collaborative, person-focused care plans, and it's essential in addressing both the physical and mental impact that COVID-19 has had on the quality of life of these residents. Please remember these services are available, and if we don't use them, we will lose them. So if you don't start referring your residents under this new program and allied health professionals don't pick it up, when the review comes in June 2022, the government will say, okay, we're not using them, we're going to take them off you. So I'd love to hand back now to David, who's going to introduce our next speaker. So thank you so much.
Thank you very much, Wendy. That was very informative and very interesting. We have had a few questions on Slido, and we're going to answer those questions at the end of all of the presenters. So don't feel that your questions are being ignored. They're not. I'm keeping an eye on them. And so we're moving now on to Polyemma Antes. She's going to talk about the role of the diabetes educator in residential aged care. Polly is an accredited practicing dietitian and credentialed diabetes educator with 20 years of working in rural and remote health, focusing on chronic health conditions. This includes working in aged care facilities to improve the nutrition status of residents. Polly has an interest in educating health professionals in updating diabetes knowledge and working with clients to improve self-management of their diabetes. So with great pleasure, I hand over to Polyemma Antes.
Thank you, David. Looking forward to this. Okay, so why would you have a diabetes educator come to your facility? I just can't quite see my slides. So education in regards to medication and side effects, assess the residents' insulin injection techniques and storage of insulin. So sometimes residents may have insulin injections only in one part of their body and develop lipo. Education to residents and staff in regards to how diabetes works in the body. So talking about the rusty locks and the leaky liver, and also how the medication works. So the flows in medications can increase the risk of thrush and urinary tract infections, so making residents and staff aware of that. And working with the dietitian to obtain optimal blood glucose levels and improve quality of life. And also to provide recommendations to the GP in regards to how BGLs may be improved. So why does diabetes management change in the older person? So as we become older and we've had diabetes for a long time, so people may have had diabetes for 20 or 30 years or longer, hypo unawareness increases, which increases the risk of falls. Also, decreased kidney function means there's a longer half-life of medications, so increased risk of low glucose events. As we become older, so after the age of 30, our muscles start decreasing. So less muscles mean less need for glucose, and so higher blood glucose levels, but also our gut motility decreases. We reduce our absorption of nutrients, so also we have different effects on our glucose levels. And most aged care residents don't just have one chronic disease, they may have many. So adding blood pressure, heart conditions, plus diabetes. We don't want to try and get blood glucose levels down to perfect to 4 because we're concentrating on the other chronic diseases. Also, if a client has cancer, we're going to have higher glucose levels due to the stress of the cancer elevating the glucose levels in the body. And reduced ability to self-care. So reduced function of their hands, not able to do their own blood glucose checks, or reduced vision as well, so are not able to do their own injections. So blood glucose monitoring changes with age. So you can see here in the table on the right how blood glucose levels change with age and different types of diabetes. So always try to make sure in the notes you refer to someone with type 1 or type 2 or type 2 insulin requiring, because people with type 1 do become older individuals, and someone with type 1 can be in an aged care facility. Someone with type 2 and needing insulin is a very different type of diabetes, so clarifying with type 2 insulin requiring. So you can see down the table, elderly residents, we want to aim for glucose levels sort of between 6 and 8 fasting and under 15 post-meal. So quite a large, varied blood glucose level, very different to a younger person with type 1 or type 2 diabetes where the range is a lot tighter. Reason for this is younger people have a longer time with diabetes, and we want to try and keep their BGLs in range to reduce complications. Older people may already have complications and their length of life is a lot shorter, so we're focusing on quality of life, not trying to prevent future complications. Also in aged care, it's very difficult to keep blood glucose levels in range because of meal times. So at home, you may eat every 3 to 4 hours. In aged care, you may eat every 2 hours. So it's very hard to do a pre-lunch BGL check when morning tea was only at 10 o'clock. So many aged care facilities will have breakfast at 8 o'clock, morning tea at 10, lunch at 12, afternoon tea at 3, dinner at 5, and then supper at 8 o'clock. So a lot of times of having lots of carb intakes, and BGLs will always be elevated by the end of the day. So what does a diabetes educator do with someone who's insulin requiring? We love flash glucose meters. So blood glucose meters, flash glucose monitoring is a really easy way, or continuous glucose monitoring, of just sussing out why someone's blood glucose levels may be not matching their HbA1c. So it measures the additional fluid of the glucose, so not the blood glucose level. So there's always going to be a 5 to 10 minute lag. With the newer models, there's no lag at all. It collects data over 24 hours. They're funded under DVA, so any residents in a DVA who have a DVA and insulin requiring can have one of these all the time. It's really great for staff to do blood glucose levels during the night. So instead of having to wake the resident at 3 in the morning and doing a blood glucose check, all you have to do is just have the sensor and walk past the resident arm and scan, and then you have a reading. So this person is 4 and going down, so they may need some hypo treatments, and wake them up to have a hypo treatment. Talk to the GP about maybe having insulin review to reduce these nocturnal hypoglycemic events. People with type 1 diabetes are able to access glucose monitoring devices for free through NDSS. Your diabetes educator can provide one free trial, and also some residents can get it under NDIS funding if they're under 65 before they receive the funding and they have a disability that affects their ability to do blood glucose checking. So that could be loss of a limb, visual disability, or other reasons to justify having a blood glucose meter funded through NDIS. Now, I just missed it. Oh, did I miss a slide? Oh, I've lost a slide. Oh no, here it is. Sorry about that. So why we do use flash glucose monitoring and CGM. So in the past, we used to focus on just doing blood glucose checks. So that point of time before the meal and after the meal. But we missed a big gap of what was happening when the person was sleeping or between meals. And then we decided almost 20 years ago, not quite, HbA1cs were the best thing, and we had to aim for people's HbA1c to be under 7. In the older resident, we aim for a HbA1c roughly of their age, just to reduce their risk of falls. And now we have flash glucose monitoring and CGM. So this looks at the whole big picture. So every 5 minutes over a 24-hour period, just to see what is happening. And variability is what we really want to look at. So now with the newer insulins, they're looking at having lower variability, which means you can have BGLs in a tighter range and less risk of having lows while they're sleeping. So the aim is to have their BGLs in a healthy range between 70% of the time, so not 100%, just 70%, and allowing for those few highs. And we want to try and reduce that variability to under 32%. And all these reports get sent to the doctor and given to the aged care facility. So you see here the difference between HbA1c and variability. The person on the top has a HbA1c of 6.5, but as you can see, they're having lots of BGLs over 10 and lots of BGLs under 4. So they're on a roller coaster of BGLs, but after the 3-month blood test, it comes back at 6.5, so looking all good. But after using a CGM or a flash glucose monitor, you can see that their quality of life is not that fantastic. So when BGLs go up really high, people become very agitated, cranky, sleepy. When they go low, become cranky, sleepy, and also always hungry. The table at the bottom, you can see this person's HbA1c, just little tiny roller coaster, little ripples of going up and down, not too many numbers over 10, no hypos or low glucose events. So that HbA1c, that person's going to have a lot better quality of life, a lot more active and feeling a lot better. Also, HbA1c in aged care can be affected by kidneys, so lower kidney function and iron deficiency. So using flash glucose monitoring, we can really pick up whether the HbA1c is a true reflection of their diabetes care, or maybe there's other factors that are affecting HbA1c and not to use that. So hypoglycemia in aged care, BGLs over 15. So why we want to really focus on this: when we have high BGLs, increased risk of urination, increased risk of thrush. So there's more glucose going through those kidneys, down through the urine system. So more thrush, more UTIs, more times of having to get the doctor for medication to treat the UTIs and treat thrush. Change in behaviour. So if anyone has seen a resident with high BGLs over 15, over 20, they are really cranky, irritable, don't really want to do anything, and increased risk of depression. So we really want to lower the glucose levels so people have better mental health. And sleepy. So people with high BGLs or low BGLs can be really sleepy and spend a lot of time in bed, missing meals, waking up at night, then eating too much or requesting more sandwiches. So again, more demands on the aged care team. And laying in bed more, high BGLs, their blood's stickier, sweeter, so the microbes on the skin feed a lot better on the lovely sticky blood, and so bacteria thrives, and then pressure sores can then become ulcers. And because of the high glucose levels, our blood flow is reduced to our limbs, and increased risk of ulcers, which means more care for the staff to look after this resident. So DKA can happen mostly with people in type 1 in aged care. Really need to watch this. So we need to make sure that, is this person type 1 or type 2 insulin requiring? So we want to stop using IDIMs and NIDIMs in aged care. So most of you would know what DKA is. So quick, sudden weight loss, dehydration, and needing to call the hospital, have the resident taken to hospital ASAP. So it's really important to have ketone testing available in aged care facilities. And this can be done with a blood glucose monitor. So hyperosmolar hypoglycemic state in type 2 diabetes happens a lot in aged care residents. It's very quick and very hard to recover from this. So risk factors of being elderly and dehydration. So residents who can't leave their bed and get a glass of water, or the glass of water is too far from their bed, or they've had the glass of water but can't refill the jug into the glass. Infections can increase blood glucose levels, so increasing HHS. Having a heart attack or a heart event can also cause this. They can have severe elevated blood glucose levels over 30, or they can be normal. So it's really hard to sometimes catch these residents. Very dehydrated, very low sodium levels. So dehydration, we really want to try and reduce in aged care, and that's where the dietitian can come in to make sure that everyone is well hydrated and have plenty of nutrition. Blood glucose checks for ketones. What you can check for is just making sure that ketones are always under 1.5, and if they're between 0.6 and 1.5, to do regular 2-hour ketone checking to make sure they don't go up. So sick day management. Every resident should have a sick day management to go what to do when they become sick or ill. So having the common cold, the flu, what to do for this resident to ensure their BGLs maintain in a healthy range. So if someone is ill, having blood glucose checks every 2 hours, checking ketones if BGLs are over 15. The Royal Australian College of GP has a really nice sick day management for people with type 2 diabetes. In this little plan, you can add in when to withhold medication, oral medication, when to increase insulin, and when to go to hospital. So it's a very easy fill in the yellow areas with the details, and it's all done. Someone with type 1 diabetes will have to just change that to individualise their needs. So seeing the diabetes educator to develop a care plan for what to do when they're ill. So tips in aged care. Everyone should have a yearly HbA1c for all residents, because the number one risk factor for developing type 2 diabetes is age. So as that pancreas gets older and the little beta cells make less and less insulin, everyone has a higher risk of developing type 2 diabetes. Also, medication reviews should be done regularly. So having sulfonylureas increases the risk of falls. And so also that poor old little pancreas may have been having sulfonylureas for the last 20 or 30 years, and it gets to the stage you're sort of flogging a dead horse. That poor little pancreas can no longer make any more insulin because all those little beta cells are pooped out. Decline in kidney function. So a lot of oral medications increase their half-life if the kidney function has been reduced. So knowing when to reduce or stop some oral medications. GLP-1s are the new kid on the block when it comes to diabetes treatment. Everyone wants to have it. It's great for weight loss, lowering HbA1c. But in aged care, we don't want everyone to lose weight because they also reduce appetite. So BMIs in aged care, we want to be between 23 and 30, so a lot higher than population out of aged care. And if people aren't eating, they're not going to get enough high protein supplements to increase their health. SGLT2s improve kidney function and can also increase UTIs and thrush. Just watch when to stop these. The gliptins don't really affect liver and kidneys. And insulins, the newer insulins, like I said before, lower variability and can reduce the number of injections someone takes, or the reduced numbers of nocturnal hypoglycemia. So I've got a little case study. Bruce is named after my son, just to highlight the fact that Bruce's were once young people. So Bruce is 85, has type 2 insulin requiring diabetes, and was diagnosed 30 years ago. He sleeps a lot, has to be woken for meals, poor appetite, doesn't participate in any activities, and needs a lot of care. He pays full price for his blood glucose strips and his needles. His weight is 58, so a BMI of 20, so high risk of malnutrition. He's still losing weight. His admission weight was 75 kgs. He's seen the dietitian and he's been put on some high protein, high energy supplements, but supplements are causing blood glucose levels to rise, and the nurses are concerned and done a referral to the diabetes educator. HbA1c 6.5. Medication is on Optulin 40 units and No Rapid 10 units with each meal, so total daily dose 70 units of insulin. There's bruising on his stomach, signs of lipo. He's using 8mm needles, and the RNs go to the same area of the stomach, the lower right quadrant, because that's the easier way to go because Bruce is sleeping all day. How do we improve his quality of life? So he's been referred to the diabetes educator. The first thing to watch, HbA1c 6.5 for an 80-year-old is very low. So what's happening during the night and during the day? So his blood glucose checks before lunch are over 10, but he's having his supplement at morning tea, so only 1.5 hours before lunch. So his BGLs are going to be on the rise before lunch, not on the downhill. So he's had a trial of a Freestyle Libre. After the first 48 hours, he was spending 25% of the time below range, so below 4, and his variability, is 45%. Made a little typo there, so big ups and downs. So how do we improve his life? So the first thing to do, talking to Bruce, he's paying a fortune for his pen needles and his blood glucose strips. So having registered with NDSS. You'd be amazed to see how many people are not registered with NDSS because it wasn't around when they were first diagnosed with diabetes, and everyone's just presumed he is registered. So always check people have a registration with NDSS. Review their insulin. So first goal is to reduce the low glucose events. Talk to the staff about rotating injection sites. So having a care plan, a chart in his bed so the nurse can cross off the area they did the injection site, so the next nurse that comes on duty knows where the injection site was, and to avoid that area and go into a different area on his stomach. And change to the 4 millimeter needles so we're not getting into muscle and causing insulin to be absorbed too quickly. The GP followed the Royal Australian College GP guidelines to reduce the Opsulin, so 4 units reduction every day until the nocturnal hypo stopped. And Opsulin was reduced from 40 units to 10 units a day. So Bruce had lost a lot of weight, so he then had less insulin resistance, so requires a lot less insulin. And the GP used a sliding scale for the Nova Rapid at meal times just to reduce the amount of insulin. So he was having 10 units of Nova Rapid for breakfast, lunch and dinner, and now it's only between 1 and 4 units at meals. A bit longer, 2 weeks later, the Freecell Libre now shows that the last week he was 80% time in range, no low glucose events, and variability was now 25%. So a lot tighter BGL range than before. Bruce is now alert, eating meals in the dining room. He's participating with other residents. The dietitian has done a review and the BGL's now up to 24. Less staff are now required to care for Bruce. 3 months later, his HbA1c is now 7.2, so still in a healthy range for an 85-year-old. Supplements have been stopped because his BMI is 24 and is stable. If his BMI reduced, then supplements, of course, would be restarted. Bruce is no longer having any UTIs. His BGL guidelines were changed, so now on waking, aiming for between 6 and 8, and before bed under 15. Nova Rapid was stopped and Opsulin was stopped, and he was changed to Rosodeg 70 and is having 10 units at lunch. So Bruce is now happy because he's saving money, having his NDSS registration, and now he's only having 1 injection a day instead of having 4. So for information in aged care, there's a fantastic book. You can't get the handbook anymore as a paper version. It's all available online, but it's using the McKellar guidelines for managing diabetes in the older person. So it's available for free to download from the National Diabetes Services Scheme. Also for aged care is the quality review tool. This is a really fantastic resource that you should use for every resident once a year. It's actually a really quick resource. And so you can screen for people to see if someone's developed type 2 diabetes, but yearly screening to see if people have type 1. You can develop type 1 diabetes at any age. Many clients I've got develop type 1 diabetes in their 70s, 80s, and even their 90s. And also just checking to see if someone's actually got LADA, so latent autoimmune diabetes of the age. So people who may have been diagnosed at type 2 in the GP setting, but BGLs never quite stayed within range, and then later the slow onset of destruction of beta cells, they actually developed LADA, so more like a type 1. So this can be a really good screening for people who may have been misdiagnosed. So a lot of older people with type 1 who are diagnosed with type 1 in their 70s were actually first diagnosed with type 2 and then realized it was actually type 1. And then everyone with diabetes should have a yearly review. So this little tool has 37 yes or no questions, and topics that are covered are admission and yearly screening, diabetes care plan, so making sure they have an NDSS registration, change of medication forms if they're required, so they get their pen needles for free, and change of diagnosis forms, check for hypoglycemia, check for hyperglycemia, and make sure that every resident has a sick day management who has diabetes, and checking for complication screenings. Are they seeing the podiatrist? Are they having the yearly eye checks? Are they having the yearly dental checks? And also the last one is just checking the facility and the staff are all trained in regards to diabetes, handling medication and storing medication. And if you need more information, Diabetes Qualified is a website run by Diabetes New South Wales and ACT, and it has lots of online courses and certificate courses for people in aged care settings. So some are 2-hour courses for diabetes for aged care workers, chronic disease self-management, administer and monitoring medication skill set. This is only available in New South Wales at present. It's going to be online and then a hands-on. So a CDE will come to your facility to do hands-on training to make sure that all staff are trained in administering and monitoring of medications, and also diabetes in practice for nurses. And it's all self-paced at your own spare time, just to increase your knowledge in diabetes, because diabetes is always changing and there's so many new medications coming on the market, and we're learning so much more about diabetes. So thank you. And then we'll have questions later after David. Pass you back on to David.
Thank you very much, Polly. Our last speaker is Rowan Davidson, who is an experienced accredited practicing dietitian with expertise in helping patients with chronic disease management, as well as an interest in gastrointestinal health. Rowan services a range of residential aged care facilities, in addition to previous work with New South Wales Health within the aged sector. Over to you, Rowan. Thank you.
Thank you very much, David. And yeah, it's a privilege and a pleasure to be able to talk tonight, give a bit of an insight into the world of a dietitian in aged care on behalf of Ethos Health. So thanks for the invitation. Okay, great. So just going to get straight into it. So it's going to be, I guess, a bit of an express overview of the role of a dietitian in aged care. So yeah, I guess I'll skip over a few things, but if there's any pressing questions, we can cover that. Okay, so just the key topics that I will look at, just briefly touch on the aged care standards, the dietetic process. That's basically giving you an insight into what the role of the dietitian and how we do what we do. And then obviously touch on the main reasons for referral, including some of those chronic disease referrals, and a little bit closer into malnutrition, which I guess is our core topic or business. So yeah, as I said, I thought I'd just initially touch on the aged care quality standards and allude to them, just because I guess it gives a bit more context and underpins, I guess, our approach and how we go about what we do. Came out in July 2019, has 8 different standards, developed by the Aged Care Quality and Safety Commission. Yeah, so it really just underpins the approach we take and how we work within the organisation. So I'll just touch on some of the standards, but I won't go into full detail. So for example, the standards are very consumer-based and resident-based, being the main focus. It's all the resident is central to care. As well as risk identification and risk minimisation. So standard 1, for example, as you can see, it's all about dignity and respect, choice, providing information along the way. So ultimately, the consumer is at the centre of their health choices. That very closely ties in with standard 2, being any input that we have that the resident is closely engaged in that along the way. So knows the reason for the referral, the reason that this strange new person is coming up to them, asking about their dietary habits. And then ultimately, if we identify and come up with a plan, that they are aware of that plan and the reasoning for that. And again, at any time that can be adjusted to suit their needs. Again, very briefly, standard 3 touching on personal care and clinical care, which is, I guess, our core business as dietitians, but also, ensuring things like processes such as malnutrition screening are quite sound and reducing risk. And just a couple of other standards. So standard 7 is all about collaboration with the rest of the staff as well. So, for example, providing in-services and staff training, filling any gaps, because, ultimately something like malnutrition and adequacy of diet is the role of anyone in that facility. So just considering supportive processes and including things like the actual mealtime environment. Okay, so I'll move on now just to talk more closely about what we do as a dietitian. So, what happens from the point that we receive a referral. So we sort of follow the ADIME process, being assessment, diagnosis, intervention, and then subsequent monitoring and evaluation. So touching on the assessment process here, and it's really putting different aspects together. It's almost like a piece of a puzzle, considering gathering as much information as we can, background information about this resident, and to kind of guide the key issue and the key problem. And then from there, trying to guide a potential intervention. So again, just briefly going through, A being anthropometry, so that's obviously important, knowing their weight history, their current BMI and how that compares to ideal ranges. Obviously, as we age, we bump up that normal BMI range a little bit. And then if possible, getting an idea for muscle mass and how they've retained that. So I can do things like arm circumference and calf circumference. Previously, I could do things like group strength as well, so that's something I might, it can be handy to incorporate as well. And thankfully, the facilities have closely monitored sort of quality indicators, so they're always monitoring weight, and within the systems, they're flagging residents who have had any weight loss. So, that's going to warrant a referral. Biochemistry and anything relevant for that particular resident might be albumin, which, looking at muscle and protein stores, level of inflammation in the body, which might guide their particular requirements, and closely looking at some nutrients that may be at risk in this population, such as vitamin D, iron studies, B12, kidneys, and of course, blood sugars. So clinical history, that looks at a variety of domains, obviously taking into account their medical history, looking at their medication use, is there polypharmacy, are there any obvious interactions, having a good feel for nutrition intake symptoms, so, assessing their appetite, has there been a change there, has there been, taste change, nausea, anything like that. Bowel regulation, is there any constipation or diarrhea, history of nausea and vomiting, all of those aspects. Social history can be important. Do they have supports from family on the outside? Do they have visitors? Are they participating well within the facility, interacting? Mobility, obviously, again, that just guides whether they've had any sort of deconditioning. And whether that ties in with that narrative of sarcopenia and frailty. Swallowing, whether it be from impaired dentition or true dysphagia, and whether it's appropriate to then assist them with a texture-modified diet, working in conjunction with a speech pathologist, pressure injuries and wounds, and obviously level of cognition and mood, and whether we need to look a bit more closely at the actual mealtime environment and all of those factors that may influence someone with cognitive decline. We then undertake your malnutrition assessment. A quick and easy and validated tool is often the MNA, and I'll quickly run you through that next. And then from taking into account all those factors, particularly clinical history, getting a feel for their actual energy, protein, fluid and fibre requirements. And the last step, of course, is getting a good feel of a detailed diet history. And this can either be talking to the resident, talking to staff, using their databases for food charting, which can, really give a lot of good information. So just seeing, I guess, and other patterns as well, like dietary balance, whether they're hitting key micronutrients, and comparing that to their requirements. So yeah, this is going to guide the key diagnosis and then intervention, which I'll talk about in a little bit. So very briefly, there's a whole, I guess, plethora of potential referral reasons. I've obviously just bolded the malnutrition there as it's the key referral reason. And yeah, alludes back to the Aged Care and Quality Commission, Royal Commission earlier this year, and identified nutrition as one of the key one of 4 components that needed closer attention. So yeah, again, touching on malnutrition, what is it? It's a deficiency of nutrients, whether it be energy, protein, vitamins or minerals, which causes measurable adverse effects on composition, function or clinical outcome. And rates of malnutrition are variable, but data indicates it can be up to 68%. So yeah, it's definitely a very real problem. And just reinforcing some of the key effects of malnutrition. So reducing independence, increased risk of falls from reduced mobility, can affect mood, cognition, just general energy and fatigue. And generally, if that resident has a hospital admission, those admissions are likely to be longer, delayed wound healing, and high risk of infections. And as I mentioned earlier, it's everyone's responsibility. So, and I guess that's part of the dietitian's role, just trying to collaborate between staff, that everyone's kind of on board, that we're all screening, that we're enforcing plans, and that we're communicating to support this. Again, very briefly, there's a whole range of potential causes that can lead to malnutrition for an elderly resident, whether it be appetite, cognition, needing assistance with meals, or actual dexterity. Arthritis can be an issue with being independent with meals. Swallowing can be an issue, and I'll touch on that. Mood can definitely be an issue, just really not wanting to partake in certain aspects of the day, as well as just general beliefs around food. You know, that's a lot of residents just may have that tea and toast type philosophy, or I don't really need much because I'm not moving kind of thing. And in conjunction with that potentially lower intake is higher requirements. So they actually have higher requirements for protein and energy. So it's kind of a double whammy in that sense. Okay, so just very briefly, as I mentioned, one of the key tools that we use for both screening and assessment is the MNA. And ultimately, it's a range of questions that's going to come out with a score to then guide the likely level of malnutrition or risk of malnutrition, which will then in turn guide a potential intervention. I will also touch on the realm of sarcopenia, as I think Polly had mentioned. It's a very real thing and a very relevant thing. I guess it's emerging more in the past decade or so and getting a greater focus, but it's this almost unavoidable age-related loss of muscle mass and strength. So yeah, it just goes along with that narrative of deconditioning, high falls risk, and can really have an effect on day-to-day activities for a resident. And there's multiple complex mechanisms that are going into this, such as just this concept of anabolic resistance, or reduced ability to be able to retain and put on muscle, and neural pathways that are related to protein signaling, certain hormonal pathways such as lower testosterone, malnutrition, and then inflammatory components as well. And I won't go through all of the detail with management, but evidence certainly indicates that a combination of both a high protein, high energy diet in conjunction with certain micronutrients combined with resistance exercise is really effective in trying to manage or prevent sarcopenia. I think since after the age of 40, every decade we naturally lose muscle 1 to 2% each decade. So by the age of 80, we can have lost as much as 30% of our muscle mass. So yeah, it's something that's obviously very relevant to be conscious of. And some studies say that with 12 weeks of intervention, of a resistance intervention, this can really, even if it retains 5% more muscle, this can translate to roughly 30% of actual strength, which can be really significant in a resident's life. Okay, so sort of moving on to the actual, what we do once we identify a problem. So this is a very broad look at what we're roughly going to be aiming for a protein target, and it's obviously going to vary for the actual individual. But if the resident is able to include 2.5 serves of meat and alternatives, which is roughly 20 grams per serve, and 4 serves of dairy, this is roughly going to come out to a reasonable protein intake of about 82 grams per day. So this is just a reference person of 70 kilograms. Obviously, there's some other protein sources within their day, within their diet, but these are the key groups that we're focusing on. So other tools that we may use to help residents get to that level, we may incorporate some flavoured milk, cheese and crackers as a mid-meal option, yogurt, particularly Greek yogurt, custard may be helpful, enriched milk, both as a drink and within certain foods. And then, of course, we may choose nutritional supplements, and tying in with the standard to really getting a feel for which preferences that resident has, which they're most likely to incorporate without any hesitation and in fact still enjoy, because that's the ideal change, adding things that they still enjoy. And, for example, if we're trying a supplement with them, making sure they've actually tasted it and are going to enjoy it, to enhance the success of this. Again, just a brief overview and difference of what a standard day might look like versus sort of a more targeted or coordinated high energy protein day. So on the right there, we're more conscious of adding full cream milk and cream to porridge, for example, adding in an iced coffee and some cheese and crackers at morning tea, fortifying a soup, whether that's adding some lentils or some cream or sausage and neutral is something we can add in. Afternoon tea, similar to morning tea, and really taking advantage of those high protein, high energy options, desserts included, and potentially supper if they're still awake. Again, other little examples of fortification. So really liaising with the kitchen to see if we're boosting the general menu and see if that's going to promote or prevent high risk of malnutrition. So whether it's a soup, adding in some lentils for extra protein and adding some cream, porridge with skim milk powder, cauliflower, add some cheese to that, and high protein custard with crumble. Very briefly, this is something, again, that we can liaise with the kitchen in ways to mix sausage and neutral. So neutral basically meaning it's meant to be invisible, taste-wise and look-wise, and how to incorporate certain amounts into certain foods to just boost the protein content. And just with the actual mealtime, it's often beneficial to be a little bit strategic, particularly with residents whose appetites are a bit limited and have that early fullness, to try and prioritise the order. So encouraging staff to offer that protein or that meat, fish or chicken aspect first. Second might be a carbohydrate along with some milk, and leaving sort of the lower kilojoule options until last, hopefully if they still have a bit of appetite. Just touching on the importance of nutrition in pressure injuries and wounds. Patients with malnutrition twice as likely to develop a pressure injury. And if there's correlated infections as well, that's going to reduce appetite. It's going to delay the healing. So again, without going into full detail, you can see there, and depending on the level of the wound and the stage of it, is going to increase the requirements further. So, up to 2 grams per kilogram of a stage 3 or 4 wound or pressure injury, and roughly 35 kilocalories per kilogram. And really trying to promote other aspects of the diet as well. Zinc, luckily, is in a lot of those protein foods. Fruit, to provide that vitamin C, which helps with collagen synthesis, as well as vitamin A, helping that immune response. Okay, of course, just touching on diabetes as well, to get a feel for the approach with diabetic clients and how we may help manage with that. I thought I'd just touch on the actual guidelines and standards and how to approach a certain resident. They're obviously going to be very different if I'm seeing a resident that is relatively healthy, still has a long life expectancy, we can have more traditional management, as opposed to an elderly resident with multiple comorbidities, unknown life expectancy, where the key aspects are just going to be avoid complications, as some of the ones Polly mentioned, and really considering quality of life. And this sort of touches on that. So if you sort of look at the third column there, the suggested HbA1c targets may increase up to, anything under 8.5% may be reasonable for that resident if they've got multiple issues, they've got cognitive impairment, and yeah, there's just that uncertain benefit. And one of the key reasons for that is it's quite critical to try and avoid any hypoglycemia, as Polly touched on, which can be, I think I'll touch on that here, yep, which can be, can trigger a cardiovascular event and can be quite serious, worsen cognitive function. So yeah, just that risk of reducing quality of life. So rather than, flagging a blood sugar level less than 4 or 5, which is sometimes the case, it may be more relevant to try and keep it above 6 or 7. So very briefly, just touching on what I may do with residents who I get a referral for diabetes for or weight loss management. So again, it's just having as thorough as possible diet history, getting a feel for what they have, what their patterns are. Because obviously the menu is set up to be fairly high energy and protein to support weight. So there's no shortage of opportunities for certain treats. So, cakes and slices at mid-meals. You've got sugary drinks. You've got things like dried fruit and desserts at both lunch and dinner. Other things that can be incorporated, certain facilities may still have vending machines or family members bringing things in as just, a way to share their bonding time, and they get stuck with a whole bag of chockies, things like that. Or the resident may not have the insight to sort of regulate their intake, or even just to know the reasons why, or the amount of carbohydrates. So intervention-wise, trying to provide a bit of education and the reasoning why, just to try and spread that carbohydrate out. It's by all means, it's not over restrictive, but hopefully just bring back to identifying anything obvious and bringing back to reasonable targets. It may be mid-meal options. It might be trying to find a option that they enjoy, whether it's cheese and crackers or fruit or Greek yogurt. Drink-wise, really trying to avoid lemonade and juice and replacing that with either water, tea, or soda water with a bit of lime, something like that. As a replacement for desserts, it might be fruit salad, jelly, a bit of low-fat ice cream. Certain cooking methods, trying to prefer grilled and steamed as opposed to fried or battered, and not just if they want an alternative option that may not be obvious on the menu, such as a salad, just making the resident aware that that's something that they can order. Okay, and yeah, just briefly, really important to not just going gung-ho with a resident who may be overweight and not just looking at their BMI and going, all right, the goal here is weight loss. We have to be conscious of sarcopenic obesity, which I touched on earlier, and it can be even more profound in higher weight individuals, because that may just facilitate that narrative of deconditioning and increased falls risk. We really need to make sure we're maintaining that muscle mass. Okay, I've just thrown this in, which may be familiar to a lot of people, just to, again, touch on the value of fibre and trying to manage, and nutrition and trying to manage bowel regulation, because obviously this can affect quality of life, it can affect infection risk. So, and may not always be easy to incorporate fibre within the typical aged care menu. So really honing in on that a little bit closer, and in conjunction obviously with medication management to try and manage that, and making sure it's monitored closely. Of course, working in conjunction with the speech pathologist, or if texture modification is indicated for any other reasons, just really being aware that any change in texture can have an effect on enjoyment of meals. It can have an effect on the actual nutrition of that meal. So again, working closely with that resident to find suitable options for them. The menu should support, have similar opportunities to a normal menu in terms of texture modified diets, and really being aware of how it's presented, presenting in a enticing way. And I guess just really supporting the speech pathology plan and making sure that's enforced for the resident safety, reducing aspiration risk, for example. And one company I might work with, or particular supplements, whether I need to consider some thickened supplements that are high protein and energy that may be relevant for residents such as this, or say a thickened pear juice which has additional fibre. Okay, and lastly, just thought I'd throw in some random potential topics with some potential emerging evidence, such as blueberries, kiwi fruit, and healthy fats. So I guess what we call functional foods, and trying to find ways to incorporate it into the menu and have residents trial these. For example, the PrediMed diet indicates some evidence of if a resident's able to have higher extra virgin olive oil or higher nuts, these monounsaturated and polyunsaturated fats, as opposed to a normal diet, this can actually prevent further cognitive decline to a degree, and they've noticed higher scores for MMSE and clock drawing test, which obviously aligns with the Mediterranean diet. Similar with blueberries, and those anthocyanins can really help with brain function. And something like kiwi fruit potentially may help with constipation. Okay, so I think that's pretty much the end of my talk. So we might throw to some general questions. Thanks for listening.
Thank you very much, Rowan. Yes, I want to thank everyone that's staying on. I know we've gone over time. I think the topics have been so huge, and we've heard some really interesting information. We already have some questions on Slido, and I think some of the questions relate to our first speaker, and there's sort of more aspects related to practicalities, such as how do you request a group service on the EPC form? Are these services available to all residents in who are regarded as high care in aged care facilities? And some problems with practice software not up to date with some of the billing aspects, such as trying to claim a visit 90035 with claiming the 93469. So perhaps, Wendy, do you have any insights into those questions?
I do, David. So let's go backwards. So yes, with the 93469, you can charge a 90035 as well. So if you were to go and see one resident, you could charge a 900.
Yeah. I think. Sorry, I think the issue is the software hasn't caught up with that.
Oh, okay. Yeah, so that's easy, depending on what software you use. So when I do it, I just do two separate bills for the day. So if a GP is billing the 90035 and the 93469, I just do two separate accounts. They get paid every time. So that's not an issue. It's just about just doing two services instead of one, just putting them as not related, which is quite simple. Sorry, Dave, what was the other question?
Are these new item numbers available to all residents in aged care facilities?
Absolutely. Anyone who's in an aged care facility is available to access these services, provided they have a care plan in place.
Right. And someone asked, one was about the practicality of how do you request a group service on the EPC form?
Yeah, so there's two separate forms. You have the individual one, so the list of all the providers is the EPC form initially. There is also a group services EPC form. So basically on Medicare's website, and just Google or just search for group services referral, the form comes up.
Thank you very much.
Charles, and he can send it through.
Another question was on, do you know of any resources to try and find providers? This person who is in Melbourne couldn't find an exercise physiologist to visit an aged care facility. So do you have any comments on how we can try and find providers who will go to aged care facilities?
Absolutely. So I've come across this myself, actually trying to find a OT for one of my patients. So the PHN is your best resource. Depending which area in Melbourne you are, contact your local PHN. They do have health pathways with lots of services, with lots of providers available there, but the PHN would be a great resource to start with. I know they're working on local directories all the time, so perhaps that or your community health centre. And also just to address depending on what clinical software you use, you have got the access to the Health Network Path address book as well, which you can search exercise physiology and it will bring up those listed in your area.
Yeah. All right. Thank you very much, Wendy. There's a question that's for Polly, and it's about the continuous glucose monitoring or the flash monitoring. Given that a lot of patients don't have either type 1 or are not covered through the DBA, do you find it troublesome trying to get people to pay for these devices? I know you said that diabetic educators can get people a 2-week trial, but what about beyond that? Do you have any tips on what you can do there?
So normally a 2-week trial, you can normally find enough information for insulin titration. Also, some aged care facilities are actually paying for these just to review residents. So they see the benefits and staff have a lot less time checking blood glucose levels and a lot lower risk of needle stick injuries. So they're seeing the benefits of using flash glucose monitoring over doing the old-fashioned blood glucose checks. And then I have a few residents who choose to pay it. So I have quite a lot of pensioners who, due to COVID, can't travel. So they have lots of spare money now and they're happy to do blood glucose checking with a flash glucose monitor just to save their finger pricks and just for their own peace of mind. So I just help them organise an order form where it gets delivered to their house once a month, 2 packets, and tell them when they want to stop. I can just stop that regular payment. So a lot of people are just finding that the $92.50, they would prefer to spend that with their money for improved quality of life and just to see more self-empowered with their blood glucose levels. So they can really see how stress and pain, so having a sore back elevates glucose levels, how stressful events elevates glucose levels, and then how different foods affect their glucose levels. And they feel more willing to eat more at breakfast and lunch because they realise that a sandwich won't elevate their glucose levels or porridge. So just that learning from food and the BGL machine. So yeah, there's a way, means in a way, and NDIS is a good way. And aged care can sometimes do it. But yeah, people with type 2 insulin requiring can get funding through NDIS if there's a disability. And then your DBA patients, it's quite easy to fill the form out. The GP just signs the need for the blood glucose monitoring device, and DBA just supplies the forms, and then the dietitian, diabetes educator just justifies why the person still needs to have this service in the aged care facility.
All right. Thank you very much. And now for Rowan. You spoke about a lot of patient factors for malnutrition, but there's a question about staff factors affecting malnutrition, such as the positioning of the meal tray, taking the meal tray away too early because it's in their routine that it's there for 20 minutes and they get it irrespective of whether the patient has finished eating the food or not. Do you have any advice on how that can be counteracted in your experience?
Yeah, very good question, and can be very relevant. And because every resident's going to be slightly different. There might be some that finish within 3 minutes and are asking for seconds, or might whiz off. Whereas residents might take 45 minutes, an hour, depending on their level of cognition and swallow function. So yeah, I guess the key ultimately will be trying to have having that awareness and having detailed care plans, particular for that resident, and ensuring that staff are communicating that plan. So this will all be documented within their systems. So yeah, I guess one, making sure it's documented, making sure it's communicated. And I guess maybe that's part of my role, to do things like in services to build that awareness and knowledge of trying to be really patient and allow all opportunities for that resident to take their time and finish that meal. Because certain residents who are at risk of malnutrition, every mouthful can really count. So hopefully it's just a combination of those things: having a clear plan, building a good culture, communicating, having the right staffing levels, which isn't always there. And one thing that Ethos ourselves have actually tried to incorporate is sort of an online survey platform that really can try and identify specific mealtime details or challenges for certain relevance, and really hone in on those sorts of things, such as posture, can they reach things, the actual environment, a whole host of things. So yeah, eventually that might be something that we can really go through with each resident and have a bit of a summary report that the facility can use. So everyone's on the same page with a clear plan for that resident.
Yeah. Thank you very much. There's also a question on how do you make the food look appetizing. This person has put in that the facility they go to seems to provide the same colour ice cream soup with different puree with every meal. So do you try and look at trying to make the meal look enticing and appetizing?
Yeah, I guess so. Ideally, I guess having a cook fresh kitchen, for one, is usually promotes a little bit better presentation. It may be very, very specific, and residents may have differing opinions on certain things. So I guess timely, allowing opportunities for feedback and allowing opportunities for things such as a resident mealtime survey to make such comments, and whether we can take that back to the kitchen and have a bit of trial and error. Like, it's never going to be perfect, but the more we take on any feedback from residents and try to collaborate with the kitchen to counteract that for the resident, then and particularly the texture modification can be a key one. There's things like molds you can use to as closely reenact the real thing. But it's certainly a tricky thing, but it just takes a bit of collaboration, I think.
And there's
thank you very much, Ryan.
There's some food companies that now sell frozen pureed food in molds, so you can break them up into plates and put them in the freezer, so the plates are already pre-done with the pretty little green molds for peas and the shape of the fish for fish, just to reduce time in the kitchen. So it costs a little bit more, but in the long run it's a lot cheaper. And sometimes giving the staff a taste test of the food all blended up into grey liquid versus a little mound of green, a little mound of red, and a round of white. So that helps as well, just for staff to realise the taste difference between one colour food and multicoloured piles of pureed food.
All right, thank you, everyone. That's all the questions.
And maybe just one last quick point. Oh, apologies.
Sorry. Oh, yes.
No, that's okay.
So I'll hand over to you, Charles. So thank you very much, everyone.
Thank you very much, David. Thanks, everyone who have stayed online with us. Apologies, we've gone a bit over, but I think it's a reflection of the wealth of knowledge that we have in tonight's speakers and the great content that they have to offer. So we really appreciate you staying on and also entering your questions for us to go through. That was a great discussion from all of our panelists. I also want to take this opportunity to thank David for your facilitation tonight, Wendy, Polly and Rowan for generously giving your time to prepare content and present. A reminder, the recording and slides will become available from tomorrow on our website in our education library. There is a third and final session in our series, and this will be on mental health initiatives for residential aged care facilities. And we're holding this via live stream as well, and it's at the same time in 3 weeks. So that's Wednesday, November 17th. So you can register for this on the same flyer that you would have for tonight. If you don't have that flyer handy, I will be sending it out again, or you can just head to our website, thephn.com.au, click on our Education Events tab, and you'll see all of our events listed there where you can register. If you would like a certificate of attendance for this evening, you will need to complete the evaluation survey in the polls tab. So you'll see that in Slido, it's sitting there ready to go. If you could just take 1 more minute of your time tonight to fill that out, we always really appreciate any feedback that you can give us. We're always looking to improve on how we can deliver education to you. So thanks again, everyone, for joining us. Thanks to our speakers. We'll leave it there. We wish you a safe and enjoyable evening. Good night.